Welcome to the October Health Law and Ethics Network seminar. As with all Helen's seminars, I want to start by acknowledging the Aboriginal and Torres Strait Islander people of the unceded land on which we work, learn and live. In particular, I acknowledge the Wurundjeri Woi-wurrung people as the traditional owners of the land where Helen and the Melbourne Law School sit. We pay respect to elders past, present and future and acknowledge the importance of Indigenous knowledge in the Academy. So our October seminar today is titled Voluntary Assisted Dying, Reflections from 5 Years On. And I'll introduce our speaker. Casey Haining is a research fellow at the Melbourne School of Population and Global Health, University of Melbourne, and the Australian Centre for Health Law Research at Queensland University of Technology. She is an interdisciplinary researcher who actively researches in the voluntary assisted dying space, and she has conducted and analysed over 100 interviews across Victoria and Western Australia. She was the appointed research fellow to carry out the statutory review of the Western Australia VAD legislation and was a legal writer for the mandatory VAD training for Queensland. Outside of VAD, she also has research interests in the end-of-life care more broadly and sexual and reproductive health and genetics. So thank you very much, Casey. Very interested to hear what you have to say, and I will hand it over to you. Welcome, Casey.
Thanks so much, Chris. Thanks everyone for joining today, and thank you for inviting me. Chris, I'd also like to pay my respects to the traditional owners of the land that I come from, which are similarly the Wurundjeri people of the Kulin Nation. And I pay respect to elders past and present. Today I'm going to be speaking about voluntary assisted dying and reflecting on some of the experiences that we've found, particularly from the Victorian experience, but also drawing on other states where relevant for comparative purposes. Like any legal presentation, I just want to begin with some disclaimers. As you can probably tell from the slide, I do have dual appointments, but this work does fit within the scope of my QT work. So I just wanted to make that very clear from the outset. I will be presenting on some empirical research today. Some of it is published, some of it is not. So if it's not published, please, not that you would, but please do not disseminate further. And I'd also just like to make it clear, as Chris noted, that I was involved in the statutory review of the Western Australian legislation. However, I will not be presenting any of the results from that review. So any WA data that I present today is not from that review. That report will be published and tabled in Parliament, but not can't disclose that as of yet. Okay. Also want to begin by just providing some context of this work. So I've had the privilege of working in this space as part of my appointment at the Australian Centre for Health Law Research, and it stems out of a broader research project that looks at the optimal regulation of voluntary assisted dying, and this is led by Professor Ben White. The broader research project is a comparative case study that looks at Australia, Canada and Belgium, and I've had the privilege of having a small role in the Australian project and working closely with Professor White as well. If you are interested in the publications from this research project, the URL is found on this slide, and so a lot of the evidence that I present today have derived from work from this project, so that's where it's coming from, that's where it's sourced. Just in terms of an overview of where I want to get to today, I do apologise, I am the only speaker, so that means that you will have to listen to my whiny voice for the duration. Just in terms of where I want to get to today is I will provide a history of the Victorian bad laws to provide that context, then provide a summary of the Victorian framework, a little bit of insight into who's accessing voluntary assisted dying, and then provide an overview of some of the evidence and recent developments, highlighting the word summary of overview. This is quite a complex area. I cannot do that in 30 minutes. So I will be really taking a macro view when I present to you today. So to provide you some context of the voluntary assisted dying laws in terms of the timeline, so really, after decades of failed attempts to introduce voluntary assisted dying laws, we see the success for the current regime really stemmed out of, first, a parliamentary inquiry into end-of-life choices, which recommended a number of things, including advanced care planning recommendations, palliative care recommendations, but most importantly for our purposes was the recommendation to introduce bad legislation in Victoria. Following that, we had a ministerial advisory panel who was appointed to provide advice to the government about an appropriate legislative framework, and they made a number of recommendations. A VAD bill was then introduced into Parliament. The bill passed on the 29th of November 2017 before taking effect on the 19th of June 2019. And so what you can see is that approximately 18-month implementation period, and that was really, really important to set up some of the infrastructure to allow the system to work, because we were really navigating uncharted waters at that time. So this resulted into what is now known as the Victorian Voluntary Assisted Dying Act. It is quite a comprehensive act. There is lots of provisions, and it is characterised by its highly prescriptive nature. It was the first Australian state to introduce modern VAD laws, which is these kind of laws that are really highly prescriptive, that now feature in multiple jurisdictions in Australia. We'll note for completeness that euthanasia was briefly permitted within the Northern Territory in 1996 when the laws were in effect. However, that was soon nullified by a Commonwealth law known as the Euthanasia Act, which removed the power of the territories to have laws in this area, but this has now been subsequently repealed. So I note that for completeness. But in terms of the modern regimes, we're talking about these highly prescriptive regimes, and Victoria was, at the time, it was really, a lot of the commentary around it was about the fact that it was the safest scheme in the world, that it had 68 safeguards, that it was going to be tightly regulated, and more importantly, that it was going to provide compassion and choice for those who are eligible. So following Victoria's lead, we can now safely say that the VAD train has well and truly left the station. And what you can see is these cascade where we see other jurisdictions now pass and introduce laws. In every jurisdiction, except for the Northern Territory, have passed laws. The Northern Territory has released recently a report that's handed down some recommendations if the government were to introduce legislation. What's really important to kind of consider is this was very much a domino effect, but Victoria really led the way, and it was really the trailblazer, but for Victoria, we probably wouldn't be in the landscape that we are today. So what that means is, although people are often critical of the Victorian regime, it really did provide the template and the momentum for the other jurisdictions. And when you reflect on it from other jurisdictions, they are very grateful for the fact that they could look at Victoria as a template, assess some of the things that mightn't have gone so well and then compensate in future laws, but also really benefited from the fact that Victoria was very open to information sharing and drawing on those experiences. What is also really coming out, or has come out of the data, is the fact that Victoria had to be conservative in its approach, because if something went wrong, particularly early in the regime, the thinking is that we wouldn't have bad laws anymore, that the whole system would be shut down for another decade. So it was really, really important. The pressure was on Victoria to kind of get it right in that sense. So for an overview of the regime, and I apologise that some people will be intimately familiar, but for the benefit of the people who don't, to be eligible in Victoria, you must be an adult, you must be an Australian citizen or a permanent resident. You must, at the time of making your first request, be ordinarily resident in Victoria for at least 12 months. You must have decision-making capacity in relation to VAD. You must be diagnosed with a disease, illness, or medical condition that is incurable, advanced, progressive, and will cause death within 6 months or 12 months as a neurodegenerative disease. It must cause suffering that cannot be relieved in a manner that the person considers tolerable. So that is very much a subjective assessment. The person must be acting voluntarily without coercion, and they must have an enduring request. The person is assessed for eligibility by at least 2 suitably qualified medical practitioners, and the requirements to be a VAD practitioner are set out in the legislation. One of the requirements, and it's a unique feature of Victoria, and only some states have adopted this, but most have not, is that one of the practitioners must have relevant experience and expertise in the disease, illness, or medical condition. And policy guidance then has interpreted that to be a specialist in that person's disease. So we have seen generally a lot of states adopt similar components of the eligibility criteria, but there has been variation as we've gone through. So for instance, the 6 and 12-month requirement is not present in all states. So for instance, Queensland just has a blanket 12-month rule. The new ACT laws doesn't put a particular prognostication limit on that. Similarly, flexibility has been inbuilt in some jurisdictions around residency requirements and whether people can be get an exemption, etc. But I guess the key component and what is really key across and consistent across all laws is that the person needs to have decision-making capacity and they need to have some kind of terminal illness, however described. In Victoria, our default is self-administration. So what I mean by self-administration is the VAD medication that person, once it's dispensed by a pharmacy, the person must take it themselves. Practitioner administration is available, but it is limited in Victoria to people who are physically incapable of self-administration or are unable to digest the substance. What is also really important to note about Victoria is that we do operate on a permit system. That means a VAD permit, whether it's a self-administration or a practitioner administration permit, must be issued by the Secretary. We also have one centralised pharmacy service, the statewide pharmacy service, which is who dispenses the medication to all of Victoria. That is based at Alfred Health. We also have supporting structures that are really crucial to the delivery of VAD in Victoria, including the statewide care navigator service. This is a service that provides information provision. It can help connect people with doctors. It offers education, training, hosts a community of practice. There's a metropolitan service that's based at the Peter McCallum cancer service within Melbourne, but there's also regional navigators that are present within the major regions of Victoria within those leading health services. We also have what we call kind of institutional navigators or institutional equivalents, and these vary by title depending on the different institution, and they're really involved in this local navigation within a particular health service. So they might be referred to variously, such as VAD coordinators, VAD program managers, VAD liaisons, or they might just not have an official title but assume that role. What is also important about the Victorian regime is that it is highly monitored. It is monitored by an independent statutory body that was set up by the legislation known as the Voluntary Assisted Dying Review Board. And that has a number of functions that are set out in the legislation. Among them is monitoring the cases that go through, but they also have roles in terms of reporting. So it will produce reports at various times. Initially it was 6 monthly, it's now annual reports in terms of providing information about who's accessing voluntary assisted dying in Victoria. But they also have quality improvement functions as well as research functions. They're supported by a secretariat that's provided by Safer Care Victoria, and they manage this system known as the VAD-IMS, which is this system infrastructure that basically the practitioners will submit various forms throughout the process, and I'll get to that in a moment, that goes through this system. It acts as a kind of regulator, if you like, that reviews the inserts a form and provides checkpoints throughout that process before the applications can be progressed. There's also community of practices. So the Department of Health sponsors a community of practice that is hosted by a PHN, and that's for medical practitioners. There's also nurse practitioners and separate community of practices, but the medical practitioner one is hosted by a PHN, and it's basically a safe community for those who are involved in this process, who have qualified to do this process for information sharing and support. So overview of the system, again, it's a very kind of convoluted system, so I'm going to kind of simplify it as much as I can. So a person makes the first request, that must be a clear, unambiguous request. Once they make that request, if it's accepted, then a first assessment must be done by a VAD practitioner who is a qualified person to carry out this function, and they assess person for eligibility based on the criteria that I described. They then go to a second practitioner who's known as the consulting practitioner, who will also make that assessment. If the person is then assessed as eligible, then the person makes a second request and a written declaration, and then they will make a final request. Once they make the final request, it's a final review, and then the practitioner will apply for a permit. If the permit is issued by the state, by the secretary, then the substance can be prescribed. Throughout this process, as I said, there's forms that need to be submitted through the online portal, which are checked periodically by the Secretariat, and if there's issues, they will go back. And that basically allows you to step by step make your way through that process. Other features or quirks, depending on your worldview of the Victorian legislation, is that doctors must complete legislatively mandated training in order to be providers in this area. This is mandated training that looks at legislatively their legislative obligations, and this is one of the safeguards in the system. The idea here is if we know our obligations, we're more likely to comply with them and we're not going to be ignorant. That's the thinking behind that. Another quirk, if you like, of the Victorian system is no health practitioner is able to raise the topic of VAD with a patient, and it is notifiable if they do so. So this means that the onus is on the patient to raise the option with their healthcare provider. The healthcare provider cannot discuss this or cannot raise this when they're talking about end-of-life options unless the patient has raised it first. Individual conscientious objection is also protected under legislation. There is limited obligations for those who wish to claim a conscientious objection, other than the fact that they need to refuse a first request or a referral for assessment within 7 days. But outside of that, there's no referral requirement, no information provision requirement, etc. Legislation is also silent on institutional participation. Provision in Victoria is also limited to medical practitioners, and this differs to other states where other practitioners can be involved in that process, so such as nurse practitioners or nurses, and they have various roles depending on the legislation and can range for being an administrating practitioner, or in the ACT, they will be able to assess for eligibility. So who's accessing VAD? Since its inception, we've had 1,282 VAD deaths. 371 deaths within the last reporting period. Really importantly, that most of the applicants that are accessing VAD are also have access or are currently being cared by palliative care service. So they're not necessarily mutually exclusive. Since the inception, we've had 318 practitioners who have been involved in at least one case. More practitioners have registered to be involved and more practitioners have done the training. But in terms of people who have actually taken on the case, it's only been 318. Mostly these comprise of general practitioners followed by oncology, and then we have a metro regional breakdown there. Okay, in terms of reflecting on the experience, so again, I have limited time today, so I am being quite selective and in terms of the data I present, which is very difficult because data is kind of like picking children for me. So I had to be very, very selective here, but I just want to, I guess, again, focus on the macro areas and to provide that context, because when we talk about issues, we generally talk about barriers or things that are wrong, but I want to really set the context is voluntary assisted dying generally has been very well received. It is considered very safe. Based on experience, and it has been considered as a way to provide a compassionate end-of-life care and another choice available to those who wish to access this. And part of the reason for this is, and one of the key strengths that we see in the system, and this is consistent, not just in Victoria, you read all the reports, and consistent is the people who are in the system. And you hear words such as beautiful humans, compassionate, they're caring, and I've had the privilege to meet some of these people and I wholeheartedly share these sentiments. And these range for people who are from the statewide services such as the pharmacy and the care navigators, to the medical practitioners who are involved in this process, to the local VAD coordinators and local navigators. These people are truly beautiful humans, and without them, it would be a completely different process. And really, the system functioning really is dependent on those. And these sentiments really reflect their compassion and the importance of them to not only provide that care and that support, but help people navigate through that process. Now going to some of the issues. So what we talked about before in terms of the limited providers is we do have a depth of providers to meet the demand. Now, you don't need to be involved in this process. It's not a requirement to be involved, but the amount of people who are involved is very limited. So that means that people are taking on higher burdens as a consequence. And there has been concerns, particularly in the last report, about the sustainability of the workforce because of these high workloads. And it's particularly difficult when you have limited specialties that are participating in this process because of that requirement that I talked to before, that one of the practitioners needs to be a specialist within that person's disease. And again, in terms of the high caseload, so what was written in the most recent report was reflecting that 10 doctors with the highest caseload over that period coordinated over 50 cases in the 12-month period. And it's really, really difficult when the burden is shared, I guess, condensed on those individuals. What exacerbates matters in this area is the fact that people are not necessarily provided the support they need to do this work. This work is incredibly time intensive. It's incredibly administratively burdensome, particularly for those who assume the coordinating practitioner role, because they have to basically take the person through the carriage of the system. And part of the issue is that people are not necessarily remunerated appropriately, particularly if they're outside a health service setting. So some practitioners can use kind of health service time to be remunerated, but if they're providing this outside of their work, it's very difficult. And MBS restrictions and the prohibition of claiming the prohibition of claiming benefits under the MBS schedule for this of euthanasia has made things incredibly difficult. There is some provision for general consultation, but outside of that, it is largely unremunerated unless a practitioner wants to privately bill or they are getting financial support from their institution. This is not other jurisdictions have taken different approaches. So a payment schedule was introduced recently in Western Australia, and we look to international experiences where we see something like a payment schedule like New Zealand, where practitioners who are working and are recognised for completing this work are paid appropriately. Another issue with the system is a difficulty connecting with the system. So community awareness about VAD remains patchy. Is VAD lawful? Can I access it? Is it just for cancer patients? And these are the misconceptions that still exist 5 years on. And also connecting to the system. If you visit your GP who doesn't know anything about it or is a conscientious objector and is not supportive, how do you find a practitioner who's going to support you? And so I talked about these kind of brilliant humans in terms of the navigators who really assist people throughout this process. But if you don't know who they are and you can't connect with them quickly, it becomes really, really difficult. And this is not just people who might have a lower health literacy or mightn't have access to technological support or technology full stop. People who are highly educated are also finding this incredibly difficult. And also compounding matters is the fact that people find it really challenging to raise VAD with a doctor, particularly if they don't know them. Again, because of that prohibition, the doctor cannot tell them that it's an option. So we really put the onus on the patient to raise this with their doctor. And this is incredibly stressful. Another issue is around institutional objection. So we do see individual conscientious objection where individual practitioners will not provide, but we also see this manifest in different ways. We might see a particular unit not providing voluntary assisted dying within a health service. That makes it really difficult to access, or we can see entire institutions. And this is not limited to religious institutions. There are secular, public-based institutions who do not provide. And part of the issue is institutions are not necessarily transparent in terms of their degree of participation in voluntary assisted dying. They might have kind of position statements, but they don't necessarily tell you much. They might say that they support a patient, but that manifests very differently across different institutions. And what are the impacts of this? Well, we see delays we see transfers, we see forced choices being made between progressing an assisted death application or receiving different types of care, adverse emotional experiences for the patient, but also the family who's suffering alongside that patient, and just a distrust in institutions full stop. And so what we see is this kind of scurrying around. We see patients being transferred and transported into various areas, whether it is on hospital grounds, car parks, gardens. I've heard of a case of a local hairdresser that a patient had to go to. So it makes it incredibly stressful for the patient, their family, but also practitioners who might be supportive, or health professionals who might be supportive, but are kind of can't facilitate that within the particular institution or unit that they're working on. However, objections are not binary. So yes, objections can cause disruption. They can be incredibly challenging, but it's not the case that just because someone has a conscientious objection, or just because an institution has an objection, that they have to be obstructive. There are certainly cases where they are, but this is not uniform. And so we have seen cases and heard beautiful stories that someone might be a conscientious objector. They're not necessarily going to support that person on that journey directly, but they're still willing to support them in other ways, referring them to colleagues, support them, be there with them throughout that journey, but just not take that kind of final step. And it's a similar observation in terms of institutional objections. It's very much an institutional lottery. You can see institutions who you might perceive might be objectors, might actually support voluntary assisted dying, but are not necessarily transparent about it, or you mightn't expect it. Similarly, there could be publicly funded institutions who you might think might support it and are incredibly obstructive. So it boils down to that whole idea of the transparency of the institution. I said that Victoria has taken a kind of very broad protection in the sense that we do not impose obligations on institutions, or we don't impose them on individuals. But this is not uniformly the case across Australia, particularly around institutional participation. We've seen an evolution of the regimes, again, using Victoria and trying to improve it, approach and trying to improve it by introducing obligations on the institutions. So that they're more transparent, so they have to provide information, and then introducing different obligations depending on the setting. So they're residential, non-residential. If it's a residential setting, is it a permanent resident or non-permanent resident? And obligations vary depending on that context. Similar with conscientious objection. So we have regimes that have evolved to introduce obligations on conscientious objectors. That includes prescribed information, providing details about navigation services, etc. So again, I talked about the point of access issue. So if you reach a conscientious objector, they don't have an obligation, you kind of hit a halt. These provisions are aimed to help facilitate them. So that individual can't facilitate that, they can connect to a service such as the Care Navigator service to help them facilitate that. Another issue is a huge issue, and it's not an issue with the Victorian legislation per se, but it's an issue with a Commonwealth, the Commonwealth Criminal Code, which has two criminal offences that are believed to apply within the VAD context. And this is because of their prohibitions of using a carriage service to discuss or counsel around suicide. And the question is VAD suicide? And so what has happened with Victoria is when the guidance came out to health practitioners, because there was fear that they would be breaching these laws, the advice was that all discussions, consultations, assessments with patients and families had to occur face-to-face. This also meant that prescriptions could not be emailed, they had to be hand-delivered or mailed. We couldn't discuss VAD over the phone because of fear that you'd fall foul of these provisions. I must say that this approach is quite conservative compared to how other jurisdictions have interpreted it. You certainly see in some other jurisdictions, they are obviously bound by the Commonwealth Criminal Code, but they've interpreted the prohibition slightly differently. So what are the impacts of this? It means that if a practitioner has to see a patient that's leaving regionally, they might have to travel extensive distances to see that patient, or the patient might have to travel to the practitioner. And this is, again, within the context of the dearth of providers in this area, is incredibly challenging. Just to putting it out there, this is not to suggest that we want a fully telehealth system, and no one's suggesting that, but we saw in an earlier slide how many different requests that a patient has to make. And so the fact that most of these need to be done in person is incredibly challenging. It also has resulted in some case, because of the delay that it results in, that people might no longer retain decision-making capacity, which means that they are no longer eligible to access voluntary assisted dying, which is incredibly challenging. This was tested. Is VAD suicide in the federal court? And the federal court said, yes, for that purposes, it is suicide. So it's a great judgment. If you are very keen on statutory interpretation, it's a really great exercise to work through, but unfortunate for the VAD context. There was an attempt to amend this through a private member's bill, but that's no longer proceeding. So outside of these kind of logistical challenges, compliance generally with the regime has been very, very high, but there has been evidence of non-compliance. And one of the examples that we see in the Victorian regime refers to a case brought against a practitioner known as Dr. Carr. And this was to do with an administrative component of the process. So what had happened was the patient had failed to sign a written declaration. So as the Secretariat was checking through the forms, it was returned. And so the doctor then got the patient to sign it, but it wasn't re-witnessed and it was backdated, so it wasn't in compliance with the legislation. So the patient was eligible, but the technical components and the administrative process was not complied with. And so what happened is this case got referred to the medical board. So the board does have those referral processes, and professional misconduct was found and the doctor was fined. But I guess what you take from this is, we're not saying this is an instance of someone who wouldn't be eligible accessing the system, but we are seeing this sense of the stringency and how serious that the state takes this. And this is really important because we want a safe system, and that was really evident within the report, in the judgment, where we see the kind of the motivation to deter behaviour, to ensure that there's public confidence in the process, to ensure that we have the highest level of professional responsibility. So what some might perceive as a harsh, it is really about the broader deterrence effect and really ensuring that we have public confidence in the system. One of the challenging cases that has arisen recently is not in Victoria, but was in Queensland, where we saw a case where we had a self-administration of that substance to a person who it wasn't intended for. So what had happened in this case, it was a rather unfortunate case that we had someone who was approved, who got access to the self-administration medication, who was stored in home, later accessed practitioner administration. Everyone complied with the legislation, but the medication had to be returned within a particular time. It wasn't, and then the spouse took the medication and then passed away, unfortunately, through that. And so this is the first case that's come across like this. It hasn't happened in Victoria, but I guess this is one of, when we talk about safety, etc., something that has been criticised. And if you read the coroner's report, they talked about how this might be an instance where we might have unfortunately favoured, in the coroner's view, patient autonomy over the safety and this unfortunate event. Again, highlighting this is very much an isolated incident, but it is an example of where something has gone wrong with the system. So where to now? The Victorian legislation has to go through a mandatory review, as does every legislation, a voluntary assisted dying legislation. But the Victorian Minister has been very, very clear that the review will not result in any changes to the legislation. So some of the issues that we talked about around, not having institutional obligations, not being able to raise VAD, not having nurses involved in the system, these are all creatures of legislation that are unlikely to be changed as a result of this narrow conception of the review process. So this means that report that has come out of the statutory review is not publicly available yet, but when it does, it'll be interesting to see what system changes might result out of that review. And I finished because I talked very, very fast. So thank you.
Casey, thank you very much. Really impressive body of work that you're putting together. I want to thank you very much. Just so everyone knows, we were actually booked in 2 speakers, but we had to make some last minute changes, and Casey very nicely stepped up to the plate and gave a really great presentation. But thank you very much. And I hope that we've got one last Helen seminar for the year, which will be on November 12th. So I hope you can then join us for then. And yeah, thank you again, Casey.